Each 1 unit change in the Prolaris score equals a doubling of risk. It's been validated on multiple tissue types, including biopsy, radical prostatectomy, actually TURP. And the endpoint of Prolaris is different. Their endpoint is what's the chances of you dying of prostate cancer in 10 years. That's their endpoint. The other endpoint that they've used also is what's the risk of biochemical recurrence after radical prostatectomy. Peter Carroll and the group out of San Francisco has actually combined this a little bit with CAPRA. This is sort of their, again, looking at, they've done this in TURP specimens, they've done this in needle biopsy specimens, radical prostate, looking at biochemical recurrence of cell and death. 3,500 patients, multiple studies. They probably have the most peer-reviewed studies out there of any of the biomolecular markers. But again, the endpoint is, the clinical question is how aggressive to treat, and again, their endpoint is what's the chance of dying in 10 years. And again, they've done a clinical utility trial, and again, when you order this test, act on the results. Don't order this test if all you're going to do is treat them the same way. And again, they have done clinical utility trials. So those are the two big tests out there for who needs active intervention. There is a third test that I measured. It's called Promark, which is by a company called Metamark Genetics out of Cambridge. Promark uses a protein. It's a protein assay. It's proteomics. How many of you remember the first company, Arion? You know, back in like the 90s. Arion was a proteomics test and it failed miserably. The problem with proteins is that they're very labile, they're hard to measure. It does give you better actually quantification. But the problem with the Promark test, and actually it got mentioned by NCCN, FDA approved it. So you can actually send off your tissue for the Promark assay through a company called Metamark. The problem is that if on your tissue staining, so when you do the biopsy, and of the urologist in the room, do you guys know what happens to your tissue once it leaves your core, how it gets processed? You know, it has to get dehydrated, and there's lots of different ways. So if there's any tissue staining, so what happens when a core leaves your needle? It goes to the pathologist. You know, these cores are very tiny, so they have to get dehydrated. It's usually through a series of alcohol baths of varying concentrations, or you can actually microwave them. Usually, if you use a series of alcohol baths, because these cores are so small, the histopathology tech in their baths will put a very small amount of tissue staining in there. Small amount of eosin, methylene blue, ink. That small amount of tissue staining destroys the proteins. So if you use any tissue staining in the process of your sampling, you can't run the test. That's one of the limitations of the test. So you actually have to know what your current pathologist is doing. But it is a test, and it's proteomic based. So in terms of now going to who needs treatment, so this is where the original Decipher test, and again, this is by a company called Genome2016, again, out of San Diego. So we know that patients who, at the time of radical prostatectomy, if they have pathologic T3 or greater disease, that there's level 1 evidence through 3 randomly controlled trials that patients should get adjuvant radiotherapy, that they actually live long. But again, there's T3 disease and there's T3 disease, right? There's a difference if you've got a positive capsule versus you've got a positive seminal vesicle versus a positive surgical margin at the apex or base or whatever, okay? So all T3 disease is not alike, but that's what the recommendation is, and basically from AUA and then as well as aspirin. But I would probably speculate that, what do you think, 20–30% of guys with T3 disease actually get adjuvant radiotherapy. I think most of us, even with T3 disease, we wait for their continence, we check their PSAs, and if their PSAs go to 0, we're kind of comfortable watching them. But again, this is the guideline. This is the guideline. It's very similar to, Ronnie and I were talking about this earlier, it's very similar to muscle-invasive bladder cancer. Those patients should get neoadjuvant chemotherapy, but only 30% of patients do. But it is the guideline. There is good level 1 evidence. So Decipher, again, the company is Genome2016, 22 marker genomic classifier. It's done on the radical prostatectomy specimen. The endpoint is it predicts metastatic progression. And again, it's going to help you to determine what patient, despite histopathology, despite PSA testing, would benefit from adjuvant radiotherapy to the pelvis. The endpoint there is the prediction of metastases at 5 years. They've released some data this past week that actually they have a molecular signature different from this, of which patients may actually respond to radiotherapy. So again, this is a different, it's called the PROTUS study, and they'll probably try to move that into the biopsy space. So again, post-radical prostatectomy, initial validation, 219 high-risk patients, low, intermediate, or high. Subsequent radiation in 260 patients, natural history cohort. Again, it's got a significant hazard ratio. So again, Decipher, Genome2016, they're playing in the space of who to biopsy, but their test, and this is FDA approved, and they're getting reimbursed, are for patients in the post-radical prostatectomy specimen who is going to be a candidate for adjuvant radiotherapy. This is what their test looks like. So again, this is sort of, again, a summary of all these tests. And again, even though you get Medicare, even though you get guideline recommendation, NCCN guidelines, it doesn't necessarily mean you're going to get reimbursed. So that's a whole different challenge. And it's probably the same for any tumor types. So, in summary, so this is sort of this schematic of what we think might be reasonable. Again, starting for PSA. If you have a PSA less than 1.5, you don't mind doing anything, and actually you could potentially alter